Hello you guys. Today I'm going to make a video about, it's similar to my top 10 clinical tips video, like things I wish I knew before I went to clinical. This is clinical, but I'm going to be focusing on more of a specific, what is the word I'm looking for? Unit. So specific floor. So this past semester, in the summer, I did a rotation on the orthopedic floor. So for those of you who don't know yet, orthopedics is just surgery dealing with broken bones. We got a lot of hip replacements, a lot of knee replacements, mastectomies, which is removal of the breasts, usually due to cancer, or it's maybe a prophylactic measure. I'm trying to think what else. A lot of total upper prostate resection, a lot of mostly hip and knee replacements, and then a lot of other random surgeries thrown in. Sometimes we get an appendectomy if the general surgery unit was overflowing, so then they just sent it over to our side. So it was one side was orthopedics and the other side was general surgery, so if general surgery was full, then we'd get it. So these are my, I don't know, I wrote them down here. I think there's a couple tips I have for things I wish I knew before I went to orthopedics and things I learned very quickly. So my number one tip to you guys is, and I learned this the hard way, is when your patient comes back from surgery, we got patients who were post-op, so they had had their surgery and then they came up, like they went to the post-recovery unit and then they came up to us. Now when you go to surgery, usually you're under anesthetic, and they wake up and the patient remains NPO, which means nothing by mouth, for 24 hours prior to the surgery. So usually they're starving. They are so hungry, and usually they want to inhale everything. They just want to eat everything on that unit, anything and everything. But let me tell you guys, this is not a good idea, because this is what happened to my patient. He comes up from surgery, I do my assessment, I chart my assessment. I ask him how he's feeling. He goes, I'm feeling pretty good. He's still on his painkillers, so I'm thinking you're not going to have a lot of pain right now, but he's feeling pretty good. And then he says to me, I'm starving, and I want to eat just everything. I want like a steak dinner. And I look at him, and I'm like, okay, well, your dinner tray is going to be here, so, you can eat. And that was my mistake. I give him his dinner tray. This guy just wolfs it down. He eats everything. The tray is clean in like 5 minutes. I go, great, the guy's eating. This is awesome. I take the tray, and I put it away. 5 minutes later, his neighbor in the room is ringing the call bell and frantically yelling. I run inside, and my poor patient's dinner is all over the place. He threw up everything. It was such a mess. So my first tip to you guys is when your patient comes up from surgery and they've had the anesthetic, usually it makes people a little bit nauseous, super nauseous, so I wouldn't recommend eating everything. You'd want to start off really light and slow, so maybe like water, soup, liquids, go from like clear fluids to like full fluids and work your way up and see how they're handling it. They're going to be hungry, I know they are, but you're just going to have to, make them trust your judgment. They're going to have to take it slow. Otherwise, you're going to end up cleaning up a lot of vomit, and it's really not that fun. Not one of the highlights of the job. The other thing is, my tips for you guys is to know your surgery as a student. You want to know what surgery your patient had so you know what to focus on. If they've had like a knee replacement, you're obviously going to want to know the status of the neurovascular status of that knee, of that leg, sorry. You're going to want to make sure nothing is going wrong. Like, you're not going to be so concerned with, I don't know, something like, okay, we're always concerned with everything, but you know what I mean, right? You're going to have a little bit of a priority going to that leg. So know your surgeries and know what's happening in the surgery. There's a lot of surgeries out there, and they're always evolving. I didn't even know every single surgery, but ask if you don't know. My other tip to you guys is know the complications of the surgery so you know what to look out for, because essentially that's why they're there. They're there to become rehabilitated if they're having the knee or the hip replacement or whatever they're having, and to make sure that nothing has gone wrong with the surgery. So you should be watching them very carefully. I'm going to list some common complications I came across in orthopedics. One of them was compartment syndrome. So this would be presented by like a pain that is unrelieved by any kind of painkiller, a narcotic, nothing, a decreased sensation, so tingling, numbness in the foot, compartment syndrome. I'm not going to go into what it is. If you guys want to know, you can go to my blog, or you can just look it up in your textbook. I'm sure it's there. So the other thing when you want to look out for is decreased mobility. Especially with the orthopedic surgery, patients don't want to move at all. They don't want to move their hips, don't want to move their legs, they don't want to get out of bed because it hurts too much. There are some very easy ways to sort of rehabilitate. So what you can do is if the patient's main problem is pain, maybe giving them a painkiller 30 minutes prior to moving them may be a good idea. So give them a painkiller, 30 minutes later, try to mobilize them. You want to make sure they get up and moving. The unit that I was on was very aggressive with mobilization. It happened the same day of surgery or day one for sure. Like they were up and moving and there was just no questions about it. So you want to make sure that's going. And then the other one was the actual wound itself. You want to make sure it's closing up, it's healing, there's no infection going on there. A lot of surgeries nowadays are done laparoscopically. Oh, I can't talk. So you don't have a big wound, you have like an entry and an exit wound where the little instruments go in. So it's really not a big deal. And another big one that I noticed was urinary retention, especially with the elderly patients. We got a lot of urinary retention, and with urinary retention, you know what happens? You get a little lovely catheter, which is not the most comfortable experience ever, but sometimes it is necessary. Another thing you guys need to know before you go to orthopedics is your narcotics. You have to know what they are, what the differences are, what the normal dosage is. Every time I had to give a narcotic, I was quizzed on what it is, what complications I should look out for, and what the dosages are, the normal dosage range for an adult. And you need to know this. And my teacher was very lovely in giving us a little card that I have actually misplaced, probably somewhere in my backpack, that had all of the dosages on it. So I would recommend you making one like that. I'll try to find it and put a picture on my blog for you guys. And that's really helpful. You can just keep it in your scrubs and yank it out whenever you need. The other thing you need to know are the side effects and what to watch out for with narcotics, especially with patients like the elderly. They may metabolize narcotics a little bit differently. So the biggest thing you want to watch out for is sedation, because narcotics will sedate patients. And you want to watch out for a decrease in respirations and consciousness, so making sure they're like awake. The other side effects of being on narcotics for a longer period of time is constipation. So you want to make sure you're on top of those bowel movements and knowing when they're happening and encouraging them to go. And if it's not happening, we'll get them onto a bowel protocol and just hand out those laxative guys. Know your precautions. Now, when I say precautions, I mean mobility precautions. Obviously, when you've had a hip or knee replacement or any kind of surgery, there's going to be a limitation in how you can move that limb. So you're going to want to know the way they can and cannot move and make sure you're reinforcing it, because there are bad patients out there who don't want to listen to you. If you say, get out of bed this way, they're going to get out of bed the other way just because they want to. And some people just don't know. So make sure you're reinforcing the precautions, because you know what you're doing and they got to listen, or they should. The other thing is assessments. Now, I'm in end of my second year, so assessments feel very routine, very regular. I feel very comfortable doing them, but I found that in orthopedics, even though you're comfortable doing it, you need to be thorough, because your patient has just undergone a surgery, which is a huge stress on the body, and every patient is going to react to it a different way. So you want to know when they come up from surgery, take a very detailed assessment. Usually it's protocol. You should check your hospital's protocols, but ours was that when they come up, you do a very detailed assessment and then you chart it, like every single detail. And that way you know how your patient came up, you know their baseline, and then, if something changes in their status, you have something to refer back to. So head-to-toe assessments are very important. Don't gloss over anything. Do everything. And especially check out that limb or the wound or whatever surgery it is that they had. And the biggest thing is documentation. So you want to document immediately and quickly. So if you do a head-to-toe assessment, I know with nursing students your documentation gets pushed to the end, but if you document as you go along, like doing your charting, it'll be much easier for you, and that way if the patient has a sudden change in status, the notes are there and you can refer back to them and everyone is on the same page and you're not going, oh, I didn't chart this, or oh, I didn't chart that. So those are, is that it? Let's see. Yeah, so those are kind of my tips for the orthopedic floor. I really loved orthopedics. It was an amazing time. I loved all the surgeries. I loved the patients. I loved doing the different narcotics and different drugs. And what I really enjoyed was that I got to learn a lot about it. You learn a lot about epidurals and PCAs, which are patient-controlled analgesics. So it's when they have a pump and it's programmed to give them a certain amount of a drug like morphine or hydromorphone or oxycodone or whatever, and they get to push a button and they get a drug, but it's not like they just keep pushing and get however much they want. There's a lockout period, and it's really cool. I got to learn about epidurals, PCAs, IVs. I'm so comfortable with IVs now because I've hung so many IV medications. I've done a lot of catheters. There's a lot of skills in orthopedics, which is great because you need them as a student, and it's so much fun. And I loved it because it was a very kind of rush environment, and you got to just do things, and there's always something to do, and it was where I felt at home. So I really enjoyed orthopedics, and I hope you guys will too. And if you guys have been in orthopedics, well, tell me what was your favorite part, or what you didn't like, or what you enjoyed, and if there's anything else you want to share with everybody else watching these videos, and just leave it in the comments below. So I hope this video was helpful to you guys, and don't forget to rate, like, and comment, and subscribe for more videos, and I'll talk to you guys next time. Bye! Okay, something I totally forgot to mention in this video, which is super important, I had it written down and circled, and I somehow managed to miss it, is neurovascular assessments. It is really important that you guys know how to do a neurovascular assessment. So I'm going to leave it up to your teachers to teach you how to do it, or your textbook, or whatever, but I'll just give you the quick way that I remember it. A neurovascular assessment is your way of assessing that limb's neurovascular status. So the blood vessels in there, the nerves, everything like that. So you're going to check for a couple of things. Let's say I had a knee replacement on my right leg. What I'm going to do is I'm going to go to my patient and I'm going to look at their leg. I'm going to look at the wound. Now, obviously, if the wound has a bandage over it, you're not going to take it off and put it back on, because then it's not good nursing practice. So you're going to check the wound. You're going to make sure if it's, redness, if there's edema, if there's any swelling or pain, and ask them about their pain level. And then you're going to move down to their toes, and you're going to check their circulation. You do this how you ask, by pressing down on their thumb to see if circulation returns within 3 seconds. You know how you do with the nails? You can use the whole thumb, because sometimes the nails are a little bit weird down there. Anyway, so you do that. You check for pedal pulses. See, there's 2 of them. There's one on the inside of your ankle, and then there's one on top of your foot. You check for... So you do your circulation, you check for your pulses, and you note if they're weak or if they're strong or if they're there. You note the color of the foot. You're going to check for warmth. And anytime you're doing this, you're not just looking at that one leg, you're always comparing it to the other. So if the leg that had the surgery was quite cooler than the other one, then you know maybe there's a little circulation impairment happening here. You're going to check for sensations. You're going to touch them and ask them, can you feel this? Can you feel this? And there are certain nerves that you test for, which again, I'll leave up to your nursing school to teach you guys. So color, warmth, movement, sensation. You're going to ask them to wiggle their toes around or move their feet around. So basically, you want to make sure that the blood supply is getting there and that they have the nerves and all the feeling there still in their leg, and nothing was nicked or cut in their surgery. Now, whenever they say they have numbness, tingling, can't feel something, it's cold, you may have a problem, and you might want to alert your nurse to it, or your instructor. That's it. Quick, super fast key points of a neurovascular assessment. I really hope I didn't miss anything, because then I'd look really stupid. Okay,